So the treatment for interstitial cystitis is palliative. So pain management and also patient education will be important. Important to educate the patient that the disease truly non-curable. There is no cure, but we can have fairly successful treatments with medications. So urinary tract infections, well, let's get back to this again. I want you to know this the list: E. coli, staph, Enterobacter, and its virulence of the pathogens important, how this develops, and how the infection develops and how the host responds. To take-home message from this slide, it will be essentially that you need to know what's the strongest, and the strongest, of course, it's E. coli, and E. coli is very closely located to urinary tract, and for females it will be the risk of contracting E. coli is much higher than for males, of course, because it comes from the GI system, and shorter urethra plays a role in contracting UTI secondary to E. coli. But again, E. coli is the most common pathogen, most common among the most common. So treatment, in primary care setting, you may not opt for culturing and sensitivity of urinary or of urine, while in acute care setting you definitely want to do it, to do culture and sensitivity. But in primary care setting, you just treat empirically with, again, ciprofloxacin or other antibiotic if patient is allergic to, I'm sorry, I said ciprofloxacin, with sulfa drugs, with Bactrim or other antibiotics like Cipro, and it's really truly empiric treatment. In cases when the UTI is persistent, you may consider definitely proceeding with UA and culture and sensitivity, and also in acute setting. If patient is admitted for UTI, you would need culture and sensitivity of the urine. But again, in primary care, empiric treatment, and most of the time it should be effective for most of the strains of E. coli. If it's ineffective, maybe we have a virulent strain and we need to do culture and sensitivity, and by sensitivity we'll find out which substance or which antibiotics will work better on E. coli. Cystitis is an inflammation of the bladder. Again, manifestations are very close to just lower urinary tract infection, frequency, dysuria, urgency, and here is you're having a manifestation of lower abdominal and or suprapubic pain. Again, the same antimicrobial therapy may help. Increasing fluid intake in either cystitis or urinary tract infection is important. Urinary analgesics and bladder irritant. Cranberry juice is maybe helpful to treat this. However, do not advise your patients or do not teach anyone to administer cranberry juice to the patient with UTI or cystitis, because you truly need a high concentration of cranberry extract to treat this, or you need a very vigorous flow or cranberry juice to treat this. Cranberry juice or cranberry extract prevents the attachment of the bacteria to the wall of the bladder versus wall of the urethral walls. However, again, it may take gallons and gallons. And one of the treatments to ask the patient to take cranberry pills. But again, this is just additional therapy, and you may need to consider the good old antibiotics and Bactrim. And again, if Bactrim is ineffective, try something else. Or patient is allergic to Bactrim, try something else. Pyelonephritis is an acute infection of ureter, renal pelvis, and renal parenchyma. So how this develops, it may very commonly come from cystitis, UTI, when we have obstructive UTI and we have a reflux of urine, then we have danger of developing of pyelonephritis. Patient will present with flank pain again, fever, chills, corticovertebral tenderness or corticovertebral angle or CVA tenderness, purulent urine. If urine becomes purulent, you better do something to further investigate why. Just uncomplicated UTI will not result in visibly purulent urine. Flank pain, fever, chills, CVA tenderness, and CVA tenderness we all know from the undergraduate assessment curriculum how to test that. But patient has CVA tenderness and flank pain, then it's big exclamation point here that patient may have pyelonephritis, needs to be treated. Chronic pyelonephritis usually may be related to some chronic obstructive source or chronic urinary retention, so also needs to be treated. Treatment is antibiotic treatment. In uncomplicated cases, you may opt for treating it outpatient, but patient, if it's a complicated case, excuse me, if it's a complicated case, you may consider hospitalization of the patient. Again, fever, chills, purulent urine, flank pain, and even patient may have some symptoms of dysuria, and which may remind you of UTI. But if you have anything on this list, you better consider pyelonephritis versus just uncomplicated UTI. And this needs to be addressed and treated as soon as you can. So fever should not be coming with uncomplicated lower UTI. Glomerulonephritis. Glomerulonephritis is the inflammation of glomerulus. So different drugs or different sources can affect this. There may be some immunologic abnormality, drugs, toxin, vascular abnormalities, systemic diseases. Also viral infections may cause this. In case of glomerulonephritis, we are observing usually a bilateral inflammation, bilateral disorder that affects glomeruli, and typically this is a sequela of streptococcal infection. Again, this may affect more men than women, and in the United States this is a leading cause of renal failure. Inflammation and with all the consequences such as congestion and cell proliferation will impair the kidney function and the ability to filter and excess and get rid basically of the excess water and excretion of harmful substances. Glomerulonephritis again can be acute or chronic, and can be subdivided or subdiagnosed as nephrotic and nephritic syndrome. And those two are really two of the most common disorders related to glomerulonephritis. When we're having a streptococcal infection, this may lead to formation of immune complexes. By immune complex, we mean a combination of antigen and antibody which circulate in the blood, in circulation, and eventually they may get deposited in glomerulus. So antibodies are good and they produced against this streptococcal organism, but the unfortunate part of this, so glomerular endothelial cells will cross-react with antibody, and the activations of complements will occur, and recruitment activation of immune cells and mediators will occur, and all of this truly results in acute glomerulonephritis. So what are the clinical manifestations of acute glomerulonephritis? Hematuria is a troublesome sign which you may notice in the patient with acute glomerulonephritis, while it's often compared or contrasted with the urine of patient with hepatitis. In this case, you actually may see like bloody tinged. It can be brown tinge, but it's definitely not hepatitis, cola, or Guinness beer color. This is more blood than bilirubin in the urine. So in this case, also your lab, one of the important lab finding in urinalysis will show casts. By no means presence of the casts means that it's UTI casts. It means that this is presentation of glomerulonephritis. Proteinuria, low serum albumin. Because of that, we're losing protein in the urine. Because of permeability, patient will start developing edema. And edema, of course, is consequence of low serum albumin. Remember that osmolarity is determined in the blood or in the serum by albumin concentration, as well as other solutes you have, but at this point albumin plays critical role, so patient will start developing edema. Because of glomerulonephritis, your patient will start developing oliguria, and oliguria, this is an old classic repeating again and again, but still I'll say that oliguria, when urine output is less than 30 milliliters an hour or 400 milliliters a day, and this is typical question from your NCLEX board exam versus one of your med-surg tests, so this is nothing new. But when in the past we were studying oliguria as a sign that needs to be just reported and to a physician or whoever, in this case we need to know, in this class we need to know that it's manifestation of glomerulonephritis. So basically, colloquially, you can say, yes, the kidneys are shutting down. So very bothersome sign. In ICU, many of you work in ICU, and urine output plays critical role measurement, and so that's why you have all these specific urine measuring Foley catheters with graduates when you can actually monitor urine output very, very closely. Nephrotic syndrome is manifestation of glomerulonephritis. So let's talk about it a little bit from antibody-antigen standpoint. So what happens, again, as I said before, this antibody-antigen complexes, which is wonderful way of immune system to react generally, which helps us a lot, but this time they are basically finding a nice lodging in glomerular membrane, and at this point they will start triggering the complement system. So that's why this is one of the points I'm telling you guys. Yes, that was all very important in the beginning to learn about immunity, complement systems, and everything else, immune responses, because here you'll see like this all in action.